Hey everyone, thank you for joining us this morning. We're just going to allow people a few more minutes to get into the webinar. Hey, it looks like the numbers of people joining is starting to slow down, so we'll go ahead and get started. Good morning. Welcome back to the 2025 NAMI New Hampshire Annual Conference. I'm Michelle Watson. Our next presentation is by Leah Rothschild, which is titled Individualizing Hope, a Person-Centered Approach to Supporting People with Mental Illness. Leah has a degree in interdisciplinary studies, earned her MSN to become a pediatric nurse practitioner, and is currently attending the University of New Hampshire to become a psychiatric nurse practitioner. She hopes to incorporate increased mental health services into pediatric primary care to provide more comprehensive care to her patients. Today, Leah will discuss hope, stigma, and person-centered care through the lens of her lived experiences with mental illness and substance use disorder, as well as her professional experiences as a psychiatric nurse and a peer recovery coach. Cultivating hope is not a one-size-fits-all approach. So just as a reminder, this presentation is in a webinar format. We've turned off the chat feature, but welcome you to put your questions into the Q&A. We will do our best to get to all of them at the end of the presentation. Before we get started, we would like to acknowledge our sponsors. Thank you to Johnson & Johnson, the HOPE sponsor for this year's conference, and to WellSense Health Plan for sponsoring Leah's workshop today. So now I'd like to turn it over to Leah to get started.
Thank you, Michelle. I'm just going to share my screen here. All right. Hi, everyone. Before I start, I just want to give the heads up. I did wake up with a little bit of a sore throat today, so I might need to pause for a little bit of extra tea and water as I go. But my name is Leah Rothschild, and I'm really excited to be here today to talk about individualizing hope and utilizing a person-centered approach to supporting people with mental illness. And I think so much of healthcare is really precise and utilizes these algorithms with clear-cut first-line interventions and medications. But psychiatry is really different, and the best treatment is often said to be the one that the patient prefers. And so that's why focusing on the whole person and not solely the mental health condition is so crucial. So I'm truly honored to be here today talking about hope through the lens of my lived experience with mental health conditions and through my professional experiences as a psychiatric nurse. All right, trying to get my screen to change here. There we go. So when I first created this presentation, I had an About Me slide first, but I realized that my lived experience with depression, anxiety, and substance use disorder has really shaped who and what I am today. So I wanted to switch things around a little and tell you about who I was before I tell you who I am. I always like to say that substance use disorder is an equal opportunity destroyer. Stigma tells us that somebody who has a substance use disorder looks a certain type of way or comes from a certain background, but that's not the case. I grew up in an upper middle class family in a nice, quiet neighborhood with 2 loving parents and a brother who was one of my best friends. I was a straight A student for most of my childhood. I had close friends, and I was a multi-sport athlete. And so from the outside looking in, I had this perfect childhood. But in middle school, I began to struggle with depression and anxiety. And I remember I would try to talk to my friends about this, and they would say things like, "You have a perfect life. What could you possibly be sad about?" And so now, on top of feeling depression and anxiety, I felt guilt and shame. I felt like I didn't have the right to feel the way that I did. And so things went on like this for a little while, and somewhere along the way in middle school or early high school, I began experimenting with alcohol and with other substances, and I found two benefits. The first is that it numbed my feelings. I no longer had to feel the depression and the anxiety that had been plaguing me. The other benefit is that word travels fast in a small town in New Hampshire. And so it really shattered this discontinuity between my external image of perfection and how utterly broken I felt inside. And so now, instead of being Leah, the girl from the perfect family and with the perfect life, I was Leah, the girl that was drinking and using drugs. And so throughout high school, this continued, and I began experimenting with more and more substances. And essentially, I just didn't want to feel like myself or be present in reality. I wanted anything to numb me, change me, or remove me. But despite my challenges, I was able to maintain my grades through high school and through the first 2 years of college. And this really contributed to my delusion that I didn't have a problem and that things were okay. But things changed in the summer of 2012. I had just completed my sophomore year at the University of Miami, and I was home for summer break when I was introduced to IV heroin. The first time that I used this substance, I felt like I had found my home for the first time in my life, and I never wanted to leave. Eventually, money ran out, and it was time to go back to school, and I panicked. I was fully opioid dependent at this point, and I had no way to continue to obtain the drugs that I needed when I got back to Florida. And so for the first time, I asked my parents for help. They took me to a local emergency room. And unfortunately, back then, they didn't have the knowledge that we have today. And so they gave me several prescriptions for controlled sedative hypnotic medications that they said would ease my withdrawals. And they sent me home with no real treatment plan and no follow-up. So needless to say, despite my best intentions, I abused the medication that I was given, and I arrived in Florida desperate and terrified. And I know I said earlier that I had no way of finding these drugs in Florida, but where there's a will, there's a way. And so I was eventually able to obtain my drug of choice in Florida, but the joy and the euphoria were gone. It was replaced by self-loathing. I wanted to stop using, so why couldn't I? I felt defective, hopeless, and helpless. Each night, I vowed that it was the last time that I would use. I swore that I would wake up the next day and I would start fresh. I attended self-help meetings. I met with a buprenorphine prescriber who gave me a taper schedule and a prescription. And each morning I woke up wanting to stay true to the promise I made to myself, but I found myself repeating my patterns and using heroin. I felt like I had no control over my own body, and I was just fully an autopilot and trapped. I became so desperate and so convinced that I could never break this cycle that on August 29th of 2012, I tried to end my life. Mother's intuition is the only reason that I am alive, because my mom was overcome by a sense of panic and dread and checked her email at the exact moment that I hit send on a suicide note. I spent 3 days recovering in an intensive care unit, and then I was involuntarily held in a psychiatric unit for 9 days. I wish I could say that that's all it took and that I was magically cured and never used drugs again, but that's not how my story unfolded. Instead, this began a 5-year cycle of inpatient treatments, sober living facilities, returns to college, and then subsequent withdrawals from college due to relapse, and even periods of homelessness. And I was trapped in this cycle, repeating my patterns of destruction over and over and over, until 2017, when I found out that I was pregnant, and for a moment, the earth stood still. For years, I did not care what happened to me. I wasn't afraid of legal consequences, health consequences, or even death. I felt that I had no worth, so I had no cares. But suddenly, there was another life involved. I went to an urgent care facility immediately, seeking help. And I remember I entered that facility with so much hope that I had not felt in years. When the provider finally came into the room, she told me that I needed to just stop using. She demonized me for my choices, and she implied that I had no business being pregnant or being a mother, and she offered me no true medical care or guidance. I was devastated, but more than anything, I was ashamed beyond belief. I was so ashamed that I returned to using drugs and was unable to ask for help again for several months. And I want to be clear that I'm not blaming this doctor for my choices. I could have used my anger and frustration as fuel to fight harder. And while I don't hold her accountable, I do want to highlight how impactful words, actions, and attitudes can be. Substance use disorders are often lethal, and we have to create safe spaces for people to ask for help without fear of judgment, because it's truly a miracle that my daughter and I survived. And so I did eventually find the courage to ask for help again. And this time I was embraced, loved, protected, and supported. And for the first time, I did more than simply going through the motions. I poured myself into recovery. I actively fought to better myself and live by the principles of honesty, integrity, hope, faith, strength. And on January 14th, 2018, I welcomed a perfect, beautiful, curious, and healthy little girl into this world. And she really is hope personified. So in my first year of recovery, I became a mother. I completed my undergraduate degree after 9 very, very long years. And after working in the substance use field as a peer recovery support worker, I realized I wanted to approach it from a different angle. Rather than trying to break the cycle of addiction, I wanted to prevent it by working with susceptible children and adolescents. And essentially, I wanted to become the provider that I needed as a child. And so that brings us back to the About Me slide. I'm now a certified pediatric nurse practitioner, and I'm currently enrolled in a psychiatric nurse practitioner program and a nurse educator program. And my dream is to work in a pediatric primary care office and provide integrated physical and mental health services to children and adolescents. I'm just really troubled by the way our healthcare system views mental and physical health as two distinct entities, despite their undeniable interconnectedness. And so I hope to combine them to offer more comprehensive care and reduce the stigma associated with mental illness. I've worked as a nurse in a substance use disorder treatment facility for 2.5 years, and this population is very special to me because of my identity as a person in long-term recovery. I've been in recovery for 7 years now, and advocating for this population is one of my passions. I live in the Seacoast area of New Hampshire with my daughter, and she continues to absolutely light up my world with her joy, her wonder, her optimism, and just her overall enthusiasm for life. So now I want to talk about hope. The theme of this conference is cultivating hope. So I want to start by talking about why hope is so important to me. And I like to address the myth of rock bottom that exists. I think a lot of people imagine rock bottom in terms of material things or external experiences. Perhaps someone who is unhoused, lost their employment, has been cut off by family and friends. And it can look like that. But when I think back to my suicide attempt in 2012, I was attending a private university in Miami. I had a brand new car and laptop. I was surrounded by friends. I was living in paradise, and yet I felt completely hopeless. And so I define rock bottom as a place of perceived hopelessness. And I really want to emphasize that word perceived because of the second bullet point that I have on this slide. There is a difference between feeling completely hopeless and being completely hopeless. So during my darkest days, I don't think it occurred to me that the hopelessness I felt may not be my reality or my destiny until the day I heard a woman say this at a meeting. And this message really may have saved my life. And so when I reflect on the power that that statement had for me, I realize the importance of delivering the right message the right way at the right time. When I entered recovery, I was introduced to what they call the promises in Alcoholics Anonymous. And it's a list of promises that will come to those who actively work a program of recovery and complete steps 1 through 9. And one of these promises is a life beyond our wildest dreams. And when I first heard this, I rolled my eyes. It sounded so hokey and so corny to me. But thinking back, I realized that I truly am living a life beyond my wildest dreams because I never could have conceptualized the life that I have today. It truly was beyond anything I could have dreamt up at that time in my life. I couldn't dream this big because I had no hope. So how do we foster hope in those who are struggling to find it? In those who cannot imagine the beauty life could one day offer? How do we bring a torch into their darkness and dare them to dream? I'm going to talk about flowers a lot today. That wasn't my plan when I made this presentation, but that's the way it happened. So I I wanted to talk about something I saw on social media once, and it was an illustration of two people having a conversation. And the first person said, "This spring I will have flowers." And the second person replied, "Oh yeah, what makes you so sure of that?" And the first person replied, "Because I planted flowers." And my initial reaction to this was wholly positive. I love this. We must cultivate our own hope. And so when we plant the seeds of hope and we water them with self-care and goal-directed behavior, the harvest is rich. And as I thought about how this applies to mental health, I thought, wow, I just need to teach my patients how to plant their own flowers, figuratively, of course. But when I started thinking about this a little differently, I reflected on my most challenging days, and I thought, what about those individuals who are in such a dark place that they cannot even hope for a brighter tomorrow? Whose gardens are so barren that they cannot fathom the idea of new growth. We cannot simply tell them to get out there and lay the foundation for a better future and to grow some hope and positivity. So more flowers here. I really love this quote that I came across. And it says, "When a flower doesn't bloom, you fix the environment in which it grows, not the flower." People are not broken or defective, and they do not need to be fixed. They need to be placed in supportive and nourishing environments that support their growth. And so to answer my question, how do we cultivate hope for people who feel hopeless? We start by recognizing that they are not the problem. We stop looking for ways to fix them because they are already capable of blooming. We reframe mental health as a more comprehensive entity that encompasses internal and external factors. And staying true to our individualized, person-centered theme, we identify the goals of the unique person in front of us. So more than other fields of medicine, psychiatry blends art and science. For reasons that aren't fully understood, some people do not respond to first-line therapies, and mental health conditions can present so many different ways because they're comprised of constellations of symptoms. So when we think about diagnostic criteria, they usually state that a certain number of the following possible symptoms must be present. And so some conditions can present with numerous domains of symptoms. They can be cognitive, they can be affective. And so generally speaking, it's nearly impossible to target all of these domains and even all of the symptoms within one domain with one medication or one therapeutic modality. And this is why treatment needs to be so individualized. Psychopharmacology is moving away from prescribing to treat a diagnosis and instead focusing on prescribing to target specific symptoms. And so now, even in my program, we're being taught not to talk about antidepressant medication or antipsychotic medication because that really limits their use, and they can be used for anxiety, for agitation, for depression, all these different things depending on what is underlying the symptom, which specific symptom is present, and how it's all kind of coming together. And so keeping this concept in mind and thinking about flowers one more time to really illustrate the point. Some flowers thrive in tropical environments, and they need that heat and humidity and heavy rainfall. And other flowers thrive in a dry, warm desert. And then other flowers, like the ones we're probably more used to, disappear each winter when the ground freezes, and yet somehow have the resilience to bloom again the following spring. And if we purchased 20 different types of flowers and we treated them all the exact same way, some would thrive, but some would wilt or even die. And so, sure, they're all flowers, right? But they have unique traits and individual needs. And so I think that's really how we need to start looking at even patients within one diagnosis or people with one symptom presentation. They are all individual. And so the interactions and the treatments need to be tailored to that individual aspect. All right, enough about flowers. I'm going to move forward and talk about having some difficult conversations with people. And these are two approaches that I actually borrowed from the palliative care field. And they've been presented as frameworks for serious illness conversations. But I think that they tie into mental health conversations beautifully and really emphasize the patient's perspective and goals of care. So I wanted to include them here. So the first acronym, NURSE, which I love as a nurse, is pretty unstructured, and it's really designed to enhance empathy and communication. So these are not steps in order. We're not moving from N to U to R. These are all just different ways that we can respond to emotion when we're communicating with someone. And so N is for naming, and that's really just identifying what we're hearing. So that could be a statement like, it sounds like you're feeling, and then we insert an emotion. And if we get it right, this offers validation. The person that we're communicating with knows that we hear them, but it also offers a chance for clarification. We might say, it sounds like you're feeling really hurt. And the person may reply by saying, I'm not hurt, I'm furious. And this is still productive because now it gives me the opportunity to show humility and empathy by responding with something like, gosh, sorry I missed that. Thanks for clarifying. I can understand why you feel furious. Sorry, I'm just going to grab a sip here. And so that statement there, I think, brings us nicely into the U, which is understanding. And this is a statement like the one I just used, validating an emotion. I understand why you feel that way. It can also be something like what I have on the slide. Thank you for sharing that with me. This really helps me understand. And so as an example, when I admit new patients at work, they almost always request to have a single room. And we have to reserve these rooms for specific medical situations, but we try our best to fill empty rooms before assigning roommates. And so I once had a patient become very upset and say that she once had a roommate destroy her belongings while she slept, including sentimental items. And so she was very fearful of that roommate situation. And so responding with understanding might be saying, thank you for sharing that with me. You must have felt so violated and afraid. That helps me understand why a single room is so important to you. And while we cannot promise that if the facility fills up, I can make a note to keep your room open unless we absolutely must fill that bed. And so this lets my patient know that they're heard and understood and that I care, but I'm also not making a promise that I can't keep. The next part of this is R, which is respecting. And this is essentially validating statements. So I have some examples on this slide. Thank you for sharing that with me. This is not easy. Or you've already taken some difficult steps toward recovery, and I can see that you're committed to feeling better. And then another example from my practice. Because of the chronic nature of substance use disorder, many of my patients complete treatment, experience of reuse, and come back. And often during admission, they express shame and say they felt like they let the staff down or disappointed us. And so responding with respect might be saying, it must have been really hard for you to find the courage to ask for help again. What I see is someone who is resilient and brave, and I'm so glad that you are here. The next letter here is our S, and that is supporting. And that is just letting someone know that you're on their team. And so this can be as simple as saying, you're not alone, or I'll help make sure your needs are met. Or a personal favorite of mine is asking, what else can I do to help you feel supported? And this really brings in that patient-centered aspect where I'm not assuming I know what support somebody needs, and I'm letting them tell me what will help them. And then lastly, E is for exploring. And that involves asking open-ended questions and really probing to gather more information and to show genuine interest in the person that you're speaking with. And so this will help us to really get a deeper understanding of who they are, what they're feeling, what they're experiencing. And as the conversation evolves, it will allow more opportunities to employ some of the other techniques on this slide. And so the ultimate goal of these statements or questions are to convey empathy, respect, and support in conversations where difficult emotions may arise. The next technique that I want to talk about is a little bit more structured. It's called REMAP, and this is another acronym. So for any of you not in healthcare, we love our acronyms. And this is intended to be used to redirect conversations toward goals of care. And so it could be used after an individual receives a diagnosis that causes an emotional reaction, or it could be used for someone who's ruminating on a negative emotion or situation. This is really just intended to shift the conversation to be future-oriented and goal-directed. So starting with R, that's for reframe. So like I just said, when that conversation gets kind of stuck and it's not moving in a positive direction, you can reframe with a statement such as, It seems like a good time for us to think about how to proceed from here. Is that okay with you? Next is E, and that's expect emotion and respond with empathy. And so because this tool is used for emotional situations and conversations, we should expect emotion and be prepared to respond with empathy. And so one phrase that can be really useful is, I can only imagine how difficult that is. And I recently attended a lecture where the speaker emphasized the subtle but significant difference between I can only imagine and I can't imagine. And so I wanted to share that with you today. I can't imagine says, I could not possibly imagine what you're going through, and I'm so removed from it that I would not even be able to imagine, and I'm not going to try. I can only imagine says, I have not lived your experience, so I don't know exactly how you're feeling or what you're going through, but I can imagine that it must be very difficult or painful. So very subtle difference in the wording, but I think the message that comes through is really, really significant. So I try to stick with, I can only imagine. Moving on from there, we want to map out individual goals. And so, like I said before, hope is not one size fits all, and neither is mental health treatment planning. So it's really important to understand individual goals before trying to tackle goals. So a great way to gain insight is to ask questions like, what is most important to you right now? Or what is most important for your future? What worries you the most? And once we start collecting this information, we have an idea of what we should target first, and what's really important to the person in front of us. And so next we want to align with values. And this is really making sure that we understood what was said. And so we want to use a little bit of reflection here. So this might be repeating back to them, what I'm hearing is that you're most worried about X, Y, and Z. Or it sounds like your biggest priority is, and we want to make sure that we did hear them and understand them correctly, and that we're all on the same page. And then once we've accomplished that, we can propose a plan. We understand their goals, their wishes, their hopes, their desires, their fears, and we can propose a plan that incorporates this as much as possible. We can open that conversation by saying something like, would it be helpful if I offered a recommendation? Or from everything you've shared with me, I would recommend. And we go from there. And so I think sometimes when we talk about frameworks like this in this generalized way, it can be kind of hard to imagine it. So I wanted to run through a couple of real life examples or case studies of how this can apply. So this first one is an experience that I had at work. I had a young patient come in, and as a reminder, I work at a substance use treatment facility. It's residential. And so I had just completed an admission, and this young woman was very intoxicated, and she has a significant trauma history, several co-occurring mental health conditions. She traveled from out of state for treatment. She expressed passive suicidal thoughts to me during the admission, and then she requested to leave against medical advice at 2 a.m. So there's a lot going on here. She's young, she's intoxicated, she's got several mental health things going on. She's having thoughts that she'd be better off dead, and she wants to leave in an unfamiliar state in the middle of the night. And so there are some clear safety concerns. And so she kept repeating to me, I just need to leave. I have other things to deal with. Coming here was a mistake. I can't stay. I'm not safe. And so first of all, I needed to reframe, because ruminating on all of these external problems was not productive in this conversation. And so to reframe and discuss safety, I said, I understand you have a lot of concerns right now, and I want to help you address those. But right now, my focus is your safety. Is it okay if I share my concerns with you? And so she agreed to hear me out, but she continued to list many specific issues that required her attention. She missed her cat. She was worried she would lose her job if she remained in treatment. And she said that her trauma history made community living really difficult. And so, responding to her intense emotion with empathy, I said, I can only imagine how difficult this is. I'm hearing that you're worried about being away from work and your cat, and that you're afraid your needs won't be met here. And so I wanted to refocus on safety. So we began discussing some of the suicidal thoughts that she had shared with me, and she insisted that she was safe. She said that she had been experiencing passive suicidal ideation daily for years and never acted on it. And so, nothing would be different today. And so I took this opportunity to use a nurse statement to explore as a means of mapping out individual goals. And so I asked, when was the last time that you remember not feeling this way? Or the last time that you felt truly happy? And what do you think would have to change in your life to get you back to feeling that way? And so we talked a little bit about that. And then I asked, what worries you the most about staying in treatment right now? And she shared that the way the rooms were set up was frightening to her, that the placement of the bed in relation to the door triggered past traumatic events. And she said she would feel safer sleeping on the bathroom floor, and she would never sleep otherwise, as she would be in constant fear. And so, aligning with her values, I said, it sounds like you're most worried about your safety. And she confirmed. And so, this allowed me to propose a plan. We made modifications to the environment to help her feel safer, because, like that quote said from earlier, when a flower doesn't bloom, we change the environment. And so her fear and her trauma history were not the immediate problem that I needed to fix. The immediate problem was that the environment was not set up to nourish her and support her individual needs. And this was fixable. And by using empathetic and reflective conversation, we were able to collaborate and find that solution. And so now, looking at a different way this could be applied, this is somebody receiving a distressing diagnosis. And I want to first emphasize that when I say distressing diagnosis, I'm referring only to a person's reaction. I'm not characterizing certain diagnoses as distressing, but instead discussing ways to navigate conversations when an individual does feel distress in response to being diagnosed with a particular mental health condition. So in this example, let's imagine somebody just received a diagnosis of Alzheimer's disease. And this diagnosis is frightening for a lot of individuals because of the gradual loss of independence and the chronic nature of the condition. So after sharing the diagnosis, the clinician or provider would offer education about the expected course, possible treatments, and overall expected impacts on quality of life. And once the patient has had time to take in the information and respond, we could begin with reframing. And so much like previous examples, this might be, given this news, it seems like a good time to talk about how to proceed. Is that okay with you? And so then responding with emotion and empathy might still include statements like, I can only imagine how hard this is, or I'm hearing that you're really concerned about the prognosis and what your life will look like now. As we map out goals, this is extremely important, of course, with this diagnosis, because as the disease progresses, the person will have less ability to express their goals and worries. And so having this clearly documented can ensure that care remains aligned with their wishes. And so this might be saying, given what you know about Alzheimer's disease, what is most important to you? What worries you the most? And so once we've heard from them, we align with their values. And so, kind of guessing what this person might have said, we might say, it sounds like you're most worried about losing your independence. Or what I'm hearing is that it's most important for you to spend time with your grandchildren. And then from there, we can start working on that plan. And I won't really dive into that because that's not the purpose of this session today, but I just wanted to give an example of how this conversation fits into that context. So we've talked about strategies for having some challenging and emotional conversations, but anyone who works in this field or loves someone with a mental health condition knows that many of these conditions present with challenging behaviors. So first of all, why is the word behaviors italicized? I really dislike this word. I hear the phrases mental health and behavioral health used interchangeably, and I really just don't like that word behavioral, because when I hear the word behavior, I have this association that we're talking about something controllable. We tell children to behave. We exert control over our behavior. And so I want to emphasize that in this context, I'm not using the word behavior to talk about something that I think we have control over. I'm using it simply just as outward manifestations of mental health conditions. So not implying that these challenging behaviors are intentional actions. So that being said, how do we talk to patients or loved ones in a way that promotes hope and healing while working with behaviors that can be challenging? How do we manage our frustrations and maintain a therapeutic and supportive relationship? So I think one of the most important things is to separate the person from the illness and the behavior. So there's an old expression that many of you may have heard, which is love the addict, hate the addiction. And while I love the message here, I don't love the phrasing. And that brings me to my next point about separating the person from the illness. The word addict is dehumanizing. It makes the disease of addiction someone's entire identity. So in healthcare overall, there's been a big movement toward person-first language. Instead of diabetic, we'll talk about a person with diabetes. And this is so crucial for all diagnoses, but it's even more pertinent for mental health diagnoses because of some of the associated behaviors and symptoms and stigma. And so some of these conditions may present with irritability or aggression or paranoia, leading to distrust of close family and unpredictable fluctuations in mood. And when the condition produces symptoms that disrupt social functioning, it becomes more important than ever to emphasize that this condition is not someone's entire identity. So separating the person from the condition is my first step toward working with some of those more challenging behaviors. The second thing that I try to do is ask myself, what is underlying the behaviors? And what this looks like to me is what need is not being met. So I wanted to go through a few case studies that I have either been a part of or observed. So the first is med seeking or medication seeking. And this is something I hear a lot in the setting where I work. People will often refer to patients as medication seeking when they frequently report discomfort and reject non-pharmacological suggestions. So essentially requesting more and more pills to manage symptoms. But when I think about this, when I have a headache, I seek ibuprofen. When I have heartburn, I seek Tums. Essentially, when I feel pain or discomfort, I seek medications to relieve those feelings. And so when patients are med seeking, we need to ask ourselves what is really going on. And sometimes this is physical discomfort that absolutely needs to be treated with a medication. They can't wish their headache away, and it's the same thing with some of these psychiatric symptoms as well. If they're feeling true anxiety, true depression, then that often warrants medication, particularly in the initial phases. But when it's just a little bit of discomfort, feeling uncomfortable in one's skin, that's when we need to really kind of work with them and help guide them to some of these non-pharmacological coping tools. But I think it really helps to understand that it's not that this person is seeking medication because they're looking to feel completely numb or to feel a high or to, feel what they used to feel from their substance use, but rather it's to alleviate a feeling of discomfort or a feeling of some type of pain. And for so long, the only coping tool that they have known is to use a substance. And so, I think medication seeking gets associated with somebody who's just looking to feel high even while in treatment. And I think most of the time it's really just somebody looking to not feel pain and discomfort. The next one that I wanted to talk about is people referring to attention seeking and difficult behavior. And so I once had a patient who had an extensive trauma history, substance use disorder, and borderline personality disorder. And she was someone who frequently presents with rapidly fluctuating moods, and she was always looking for an external source of frustration to blame for her anger and her sadness. So if a staff member walked by and said, "Hey, what's up?" instead of, "Hey, how are you?" they are rude and insensitive. If somebody asks follow-up questions to gather more information when she's upset, they're insensitive and not validating her emotions. And so there was one night where she was listing several frustrations to myself and two other staff members, and we kept making suggestions. Have you tried X, Y, and Z? What about, these solutions? And after 20 minutes of this, she screamed, "You think I haven't thought of all of this or tried these things? I've tried everything. I am sick of you trying to solve everything." And so the other staff members walked away, and I paused and I said, "It sounds like you aren't looking for a solution right now, but you just want to vent and feel heard. Am I hearing you correctly?" All she wanted was an ear. I sat with her in a dark room for 2 hours listening. She cried, she shared some of her trauma, and eventually things shifted. We talked about her cat that she loves. We talked about her career goals. And so on the surface, she presented as being difficult or argumentative or somebody just refusing help but wanting that attention and lashing out. But underneath that, there was a lot of pain and somebody who desperately wanted to connect and just feel truly seen and heard. And so, in a sense, she was indeed attention seeking. But don't we all need attention and validation? Sometimes people don't know how to ask for what they need. But with a little bit of patience and empathy, we can uncover that. And so the last one I wanted to talk about is aggressive behavior. And this is something that I observed during one of my first ever student clinical rotations several years ago. And I observed an inpatient pediatric patient in a hospital. He was hospitalized for a mental health condition. He was a preteen and he was extremely agitated. He had broken the sink off of the wall in his hospital room and he was screaming. And so the first staff to arrive immediately closed the door and kept him in there and called for security. And so this left this child throwing himself against the door and screaming. And while we were waiting for security, another nurse arrived and opened the door. And the child kept screaming, "I hate you, I'm going to kill you." And the nurse remained calm. And she said, "You seem really upset right now. Tell me what's going on." And this dynamic went back and forth for a couple of minutes until finally the boy began to cry, dropped to the floor, and mumbled, "I want to kill myself." His depression was so painful that he masked it with anger. Other staff had wanted to put him in seclusion or restraints, but the compassion and patience of one nurse was enough to unmask the true source of pain for this patient. And hopefully that allowed him to begin that process toward recovery. So these are 3 examples of some of the more challenging situations that I have encountered and how I or others have worked through them. But what about when we can't step back and reframe the patient situation? What do we do when we can't dig beneath those surface behaviors to find the unmet need? Or when we're so triggered by a particular patient or person or behavior, and it brings up uncomfortable feelings in us that we don't know how to deal with? And so the first thing to do is to ask for guidance or help from a supervisor or from a professional. But the second big thing is to take time for self-care because compassion fatigue is real. And so unfortunately, I don't have the time to dive into this topic too deeply right now, but I will be hosting a workshop during the lunch hour to talk more about self-care for anyone interested in this topic. But just kind of a brief introduction to it. Anyone who works in the mental health field or who cares for someone with a mental health condition or any special healthcare needs is probably familiar with burnout and or compassion fatigue. When we pour ourselves into the care of others, we can experience mental and physical exhaustion, decreased performance, decreased empathy, and negative attitudes. And it's crucial that we take the time to nourish ourselves and care for ourselves, just as we prioritize caring for others. So if you're interested in learning more about this and participating in a fun activity to assess and enhance your own self-care, please join me during the Lunch Expo. Now back to our scheduled program here. I wanted to shift gears again and talk about the concept of neuroplasticity and its relevance to hope. So neuroplasticity refers to the brain's ability to form and reorganize synaptic connections. And so when I was first hospitalized following my suicide attempt in 2012, one of the doctors essentially told me and my family that I had ruined my brain and permanently altered my brain chemistry through years of using drugs. That this repeated exposure to drugs and the repeated behaviors that were overactivating the reward pathway in my brain had damaged me and I would never fully recover. So there I was, more depressed than I had ever been in my life, and I was told that these chemical changes were permanent, that this was my life now. But several weeks later, when I began a partial hospitalization program, they returned a small glimmer of hope to me. They told me that I had not ruined or damaged my brain, and that the chemical changes were not permanent, and that just as years of substance misuse had rewired the neurocircuitry in my brain, so could recovery. And so neuroplasticity is a source of hope. We're learning so much about the brain's immense capacity for change. We can rewire and retrain our brains. And of course, we cannot simply train our brains to no longer experience a mental health condition, but we can rewire the way we perceive certain aspects of our diagnoses. And with each new discovery about the brain, it becomes more and more apparent how much we don't know still. And so there is so much room for more research and more discoveries and novel treatments and hope for better pharmacological and non-pharmacological options for managing symptoms of mental health conditions in the future. And so thinking about neuroplasticity, this is part of why the expression in Alcoholics Anonymous and Narcotics Anonymous meetings, fake it till you make it, works. And so when they use this expression, they're referring to going through the actions of recovery, even if you don't feel ready. And over time, this repetition could create new neural pathways and rewire the brain for recovery. And I envision it like walking across a field after a fresh snow. And so at that point, there are no pathways. It's completely smooth. And if you walk across one time, there will be a line of scattered footprints. But if you walk that same path every day, eventually you will kind of squish down the snow and make this clear path across the field in that spot. And so when we think about the brain, repetition of healthy behaviors can lead to these healthy pathways being formed over time. When thinking about ways to cultivate hope, I think it's really important to also understand the existing barriers. I briefly researched barriers to hope, and while I encountered topics like isolation, trauma, pervasive negative thought patterns, the most significant barrier that I kept encountering was stigma. And fighting stigma is so important to me because stigma ends lives. It contributes to fear and isolation, and it prevents us from reaching out and asking for help when we need it. In 2021, my daughter lost her father to an accidental opioid overdose. And at the time of his death, he was working at a well-known recovery community organization. He had close friends working in substance use disorder treatment across the country. He had previous periods of long-term sobriety. He was so connected to so many resources for recovery, but stigma made him too afraid to ask for help. Stigma ends lives. And so it's so important that we fight stigma so that we can keep people alive. But the other reason why stigma is so important to me is because the stigma surrounding substance use disorder will allow my daughter to grow up hearing that she lost her father because he chose drugs over her, or because he didn't love her enough to stop using. When in reality, he was silently fighting a battle against his substance use disorder and he loved her immensely. So we need to use our voices to advocate and to fight against stigma so that we can keep people alive and keep the loved ones who have survived after death protected from hearing these messages that just aren't true. So this is my last topic here. I know I'm getting close to running out of time, but when discussing stigma, there's one particular topic that I like to highlight that I think has been extremely stigmatized, and this is medication-assisted treatment. When we think about stigma, I think for a lot of people, what first comes to mind is this kind of external stigma, which is the stigma placed on a group from people that are not within that group. And so that would be, when we think about medication-assisted treatment, healthcare providers or the general public stigmatizing that. But there's also internal stigma. And this, in this particular case, would be a stigma coming from within the recovery group. And both of these stigmas can be equally damaging. And so this topic has been heavily stigmatized by all. Certain recovery groups have maintained that individuals are not truly sober if they're using certain medications, such as buprenorphine or methadone. And for anyone here who's not familiar with these medications, the very, very short version is that they're prescribed either short-term to treat withdrawals from opioids or long-term to prevent cravings and relapse in people with opioid use disorder. And they work by binding to the same receptors in the brain that opioids like fentanyl or oxycodone bind to, but they do not produce the same euphoria or intoxication in people who are opioid dependent. So people in certain recovery communities have ostracized individuals who utilize these medications to supplement their recovery, stating that they're still using drugs. And I've even heard healthcare professionals perpetuate this misinformed belief with comments such as, well, they can't stay on that forever. It's just replacing one addiction with another. And this is 100% not true. When used as prescribed, these medications do not produce a high. They are life-saving medications. And when I hear healthcare professionals wondering when a patient will stop taking that and speculating that they should probably come off of it, I try to remind them that we wouldn't say that about someone who requires medication for their diabetes or for their high blood pressure. So why do we place a time limit on these medications? And according to their FDA approval, there is no time limitation on the safety of their use. They're intended to be used as long as necessary and as desired by the individual taking them. And the stigma is really tremendous. Like I said, both within the larger community and within recovery communities. But the stigma within recovery communities is particularly concerning to me because it drives people away from additional supports that may be necessary for their recovery. So while medication alone may work for some people, most people still need to participate in peer recovery programs or other therapeutic modalities. And for them, the medication assists their recovery. But if individuals utilizing medication-assisted treatment feel unwelcomed by recovery communities and are made to feel ashamed or less than, they may choose to stop accessing these vital services. And this can be the life raft that helps keep so many people afloat and alive. So it's really crucial that we advocate for all pathways to recovery and that we support individual choices. And my main takeaway here can be generalized beyond this topic. There are numerous pathways to recovery from any mental health condition, and there is no single correct path or best path. It has to be patient-centered, person-centered, individualized care. So in conclusion, I want to return to the question that I posed at the beginning of this presentation. How do we help to cultivate hope in individuals who are in such a dark place that they cannot even hope for a brighter tomorrow? And the answer is, we express genuine empathy and compassion. We seek to understand their goals and concerns so that we can tailor our care and support. We offer unconditional and unwavering care and support. And we remember and remind them that feeling completely hopeless is not the same as being completely hopeless. When we individualize care, we individualize and cultivate hope. So thank you so much for being a part of today's conversation on cultivating hope. I hope that some of you join me during the lunch break for further conversations about balancing self-care with the care of others. And we've got a little bit of time left for some questions.
Thank you so much, Leah. So for those wondering who the random voice is talking right now, this is Jace Troy. I'm the Community Engagement Coordinator at NAMI New Hampshire, and I'm just here to ask some of the questions that are in the Q&A. So if anyone else has any other questions, please feel free to put them in the Q&A now while I read these ones. The first question that we have is from Teresa, and she said, "What did you go through at the end of your recovery process to finally break through?" And I think we mean at the end of your substance use.
So unfortunately, I think the real answer to that is a little bit longer than I have time for. But for me, it was working the program of Alcoholics Anonymous that worked for me. And I want to be clear that I'm not here to endorse any specific pathway to recovery. That is just what happened to work best for me. But it's something I had tried kind of halfway for many years. I had shown up to meetings or I had asked someone to sponsor me, but I had never really committed myself to doing the work with a sponsor. And so that was the big change, is I made a commitment to working that program, and it worked for me. It changed my life.
Thank you. The next question is, will the slides with the acronyms be sent to us in a printable version?
I do not know. I am definitely happy to share them if there's a way they can be distributed.
Okay, yes, we can distribute those for
Yes,
sure,
we
as
can,
long as you're
yes,
comfortable
we can
with
take
that.
care of that. Yep.
Question from Bobby Ann says, "Leah, you are an extraordinary and such an amazing speaker. Thank you for sharing your knowledge and hope. How do you continue to evolve and stay strong when surrounded by others who are actively struggling?"
So self-care, which I will talk a little bit more about during the lunch session, is a big one for me. Making sure that I'm taking time for myself and recognizing some of those signs of burnout or compassion fatigue, and knowing when I need to step away. I think the other thing is I have created kind of a condensed recovery program for like a recovery maintenance. And it's like just kind of like a mini version of the 12 steps where I try to just kind of check in with myself nightly and look at, where could I have done better today? What would I like to improve on in myself? And just doing these kind of like nightly reflections and check-ins, and trying to maintain ongoing growth. Because for me, staying stagnant is kind of the opposite of recovery. Recovery is synonymous with ongoing growth. So not sure if that really answered the question, but I just need to make sure that I'm staying in touch with myself and my needs.
Yeah. Thank you for that. I see that someone raised their hand, but I don't believe you have the ability to unmute. So if you are okay with putting it in the Q&A, that would be wonderful. And we have a lot of thank yous in the Q&A for your presentation. Someone said, thank you so much for this amazing presentation. Someone else said, thank you so much for a powerful presentation. Your perspective on person-centered care is spot on. Today is a proud day for individuals with lived experience of behavioral health conditions. We celebrate you and other hope givers. Thank you for fighting the good fight.
Thank you.
And we have another thank you from someone that says, thank you for your bravery and vulnerability and sharing your story. Please continue to pursue your goal of reaching patients who are at risk before they become reliant on substances. Parents who are seeking support for their children who are exhibiting at-risk behaviors, suicidal ideation, experimenting with drugs and alcohol, sexual promiscuity, self-harm, etc., are treated as overreacting, catastrophizing, and appropriate proactive treatment is put off. When I start trying to get my son treatment, he was experimenting with alcohol and weed. We could not get approval for an increased level of care until he was doing crystal meth. That could have been avoided if people with your mindset were the decision makers. Please continue your important, probably difficult work because it will have an impact.
Thank you so much for sharing that. And I'm so sorry that that was your experience. And, that is exactly what I hope to prevent going forward.
And the last comment I see here says, thank you for not forgetting the youth.
So thank you, Leah, so much for this amazing presentation. It was just wonderful. And I actually didn't need to use too many tissues this time.
Thank you so much for having me here today.
It was wonderful. And I know Leah did her little promotion for her piece during the expo, and I just want to remind all of you about that expo as well. But thank you all for joining Individualizing Hope, a person-centered approach to supporting people with mental illness. Next up at 11:15, we have NAMI Walks New Hampshire, bringing hope, help, and healing to the Granite State, presented by Brittany Porter, NAMI New Hampshire Walk Manager. There is also a giveaway associated with attending that session in case you needed a little extra push. Please make sure to review all of the amazing sessions we have prepared for you today, including our afternoon keynote presenter, Kim LaMontagne, and shortly after that, a presentation from New Hampshire Governor Kelly Ayotte. As we talked about the expo during the lunch hour, there are instructions from the lobby how to get into it, as well as I will be doing some screenshots at the end of the walk session. Please keep an eye out for the evaluation that will be emailed to you at the end of the conference. We appreciate your feedback on this session and the conference as a whole. If you need a certificate, you will be able to download one after completing the survey. A recording of this session and all of them will be available in this conference lobby later this week, as well as on the NAMI New Hampshire website and YouTube channel. And we can actually upload, if you want, Leah, those acronyms that somebody asked about, we can put those in the conference as well. So thank you, everybody. We will see you at 11:15 and have a great afternoon.